Dr. Mary Ackerley directs My Passion for Health in Arizona, where she treats patients with biotoxin illness. She is co-founder and first president of the International Society of Acquired Environmental Illness.
Hi, everyone. If you don't know me yet, my name's Mary Ackerley, and I'm an integrative psychiatrist in Tucson who's been working with mold patients for more than 10 years. I'm here today to discuss current research on inflammation and neuropsychiatric illness and to explore the potential contribution of chronic inflammation caused by biotoxins to this research. I believe the evidence for inflammation and infection playing a major role in psychiatric illness and the persistence of mental disorders and cognitive impairment is well established by this time in 2021. And I hope that by presenting the evidence here for this statement and by showing how it applies to inflammation caused by biotoxins, that EMF researchers can focus more effort on demonstrating a similar link between EMFs and cytokine disruption. Depression is a very common illness, and it's about 17% of the population will have one episode in their lifetime. And WHO has predicted that by 2013, depression will cause more disability and mortality than any other illness, including cancer, cardiovascular disease, and mortality from accidents and war. And after 2020, these numbers may be accelerated. It has been known for a number of years that antidepressants are no better than placebo for mild or moderate depression, and only about 10% more effective for the severely depressed. In fact, a good clinical rule of thumb is that SSRIs get about 50% of patients about 50% better. However, these facts do not discourage clinicians and patients from using antidepressants. 250 million prescriptions are written a year. That translates into 1 out of every 10 patients in the US being handed an antidepressant prescription. And what an amazing fact this is, given that there is no generally accepted clinical trial for depression, clinical test for depression. That's right. 1 in every 10 US patients, and that number keeps growing, are given a prescription for an illness that has no objective tests for diagnoses. And so I could believe some conclusions can be drawn. First, maybe psychiatry is looking in the wrong place for answers. There's more to the brain than neurotransmitters. For instance, diagnosis is oversimplified. Even the head of NIMH has come out and stated that functional and structural brain imaging research has not been able to find consistent correlations with classic psychiatric diagnosis. So I think we can all agree there's some room for improvement here. Today, I'm going to be going fast and furious through a lot of different realms, picking out clues here and there to show associations between exposure to water damage, immune and hormone dysregulation, and the causes and the effects of these dysregulations are neuropsychiatric functions. I'm going to be talking about IL-6 and other inflammatory cytokines, neuroinflammation and neurodegeneration, the secrets of VEGF, what it means when a doctor tells you there's nothing wrong with you that psychiatry can't cure. And I'm also going to be discussing sick cats, healthy mice, and prairie voles that mate for life. So let's go. Now, the psychiatric community is aware of the data I just reported, and as you can imagine, it stirred quite a passionate debate. Thankfully, the role of chronic inflammation has been receiving increasing attention. And here are the titles of some recent articles: Inflamed Moods, not bad. The role of microbes and autoimmunity in the pathogenesis of neuropsych illness. Long-term inflammation increases the risk of common mental disorders. And my favorite, so inflammation is an inflammatory illness, but where does the inflammation come from? I think most of us in the SIRS and Lyme community could give these researchers a few hints. Okay. This slide presents factors contributing to chronic, non-resolving inflammation and disease. Numerous environmental and biological factors can conspire to contribute to chronic inflammation, including obesity, diet, early life stress, psychosocial stress, permeable gut epithelium, T cell dysregulation, including Th17 and anti-inflammatory Tregs. And the results are, through multiple studies, chronic inflammation is now recognized as a gateway to major neurodegenerative diseases of modern society, including cardiovascular, neurodegeneration, diabetes, cancer, and depression, all the big ones. And I've always thought there's something missing in this slide, so I've added it for you. You can see CIRS, or chronic inflammatory response syndrome, from mold. And for this conference, I added EMFs as other causes of chronic inflammation. And CIRS is often mistaken for a neuropsychiatric syndrome such as depression and anxiety. CIRS, or chronic inflammatory response syndrome, which you are hearing my colleague Dr. Bernstein present in more detail, consists of many symptoms spread out through multiple organ systems, and the sheer complexity of just cataloging every symptom, which is what physicians commonly call a review of systems, overwhelms a typical high productivity practice, which needs to be seeing patients every 15 minutes. And what that means in practical terms is that a busy PCP has about 30 seconds to listen to a patient, then grabs the most prominent symptom displayed and runs with it. For many patients, the neuropsychiatric presentation of tearfulness, mood lability, and confusion is prominent and leads to a very fast prescription of Celexa or Xanax. Now, the multitude of symptoms seen in CIRS is overwhelming and challenges diagnostic algorithms. So here again, quickly, energy, respiratory, muscular, neuro, GI, and again, Dr. Bernstein will be covering this in more detail. We see ophthalmological, pain, dermatological, cardiac, endocrine, and just weird. And really, very few patients get through the ordeal of getting a proper diagnosis without hearing the suggestion that they'd be better off just seeing a psychiatrist. So now you begin to understand why, once I started to learn about how to recognize CIRS, I found a number of patients suffering from it had already been pointed in my direction. Most patients, when I see them for the first time, have had at least one or two neuropsychiatric symptoms present, such as the mood swings, reduced resilience to stress, generalized anxiety and panic attacks. Anxiety is probably the most common symptom I see, along with insomnia. Cognitive impairment, also known as moldy brain, with poor concentration, focus, short-term memory, lack of motivation, difficulty planning and executing, easily irritated and angered, with loss of impulse control, and suicidal ideation, usually passive, but can also be present. So this is what it means when a doctor tells a patient, there's nothing wrong with you that psychiatry can't cure. It means your physical symptoms have been explained away as somatic manifestations of a primary mood or anxiety disorder, which is allowed in DSM-5. And actually, there aren't many symptoms that can't be explained away as a somatic or physical expression of anxiety and depression. You know, take a look here for anxiety: tremors, twitches, numbness, tingling, frequent urination, insomnia, shortness of breath, chest tightness, palpitations, diarrhea, dizziness, irritable bowel. All can be seen as just somatic manifestations of anxiety. And for depression, fatigue, hyperinsomnia, musculoskeletal pain, constipation, weight gain, weight loss, reclusiveness, the lack of focus, lack of concentration, irritability. You can see that when a physician is hearing these symptoms, he will just immediately shorten the whole presentation to depression or anxiety and tell you there's nothing here that the psychiatrist can't fix. And this was actually seen in one of my patient's charts written when the neurologist saw him. He just wrote, nothing wrong with this patient that psychiatry can't cure. So this is probably the most important slide I'm going to show. It's how to inflammation-induced sickness behavior from the psychiatric syndrome called major depression. Sickness behavior is a well-studied phenomenon in animals, which is based on high cytokines. It involves malaise, fatigue, psychomotor retardation, and social withdrawal. Think of how your cat or dog behaves when it's sick. It hides, doesn't eat, doesn't find joy in its normal activities. However, in people, we tend to label the same behaviors as reclusiveness, fatigue, anhedonia, loss of pleasure in usual things, and we call it depression. So now we begin to see how the DSM-5 checklist of symptoms could be lumping different syndromes with different causes all in one heap called depression. And most of the current literature on sickness behavior focuses on how enhanced pro-inflammatory signaling can promote the development of depression, which is seen as evolutionarily beneficial because it conserves resources. You hide and allow your body to heal. It's just in modern times, when the inflammatory response goes on too long, harmful effects are seen, such as the cardiac illness, metabolic syndrome, neurodegeneration, and depression we've been talking about already. Now, the major point I want to make is guilt, worthlessness, and hopelessness are not seen in this evolutionary advantageous behavior we call sickness behavior. When you're seeing guilt, worthlessness, delusions of having done something very bad, complete hopelessness, you may be looking at what we call a major depression. It's important to differentiate. Okay, so this is also a list here of some infectious and neurotoxic pathogens that have been associated with psychiatric illness. So it is more than inflammation. Many infections have been associated besides inflammagens such as biotoxins, certainly neurolyme co-infections, well established as a cause. Neuropsychiatric illness, strep is a cause of OCD, what we now call pediatric autoimmune streptolysin, seen as OCD, multiple encephalopathies such as viral. We now are seeing it many times in COVID and what we call the long haulers. It was certainly seen in the Spanish flu. Toxoplasmosis carried by cats has been associated with suicide and schizophrenia. So we do have a few studies showing exposure to water damaged buildings is correlated with dose depression and cognitive dysfunction. And here's a study done in 2007 in Europe on almost 6,000 Europeans living in visible mold, which found about a 40% increase in depression over residents in buildings without visible mold. Notice I didn't say they were living in mold-free buildings because it's very rare, really, to see visible mold in most patients' home. And certainly non-visible mold causes the majority of the inflammatory effects that I see. So here's some really good scientific evidence, actually, that's been around for a while, that mold does contribute to depression. My brain doesn't work the way it used to. Most common complaint I hear from many patients. And there are several studies documenting that cognitive impairment is real and reversible with reduced cognitive functioning, poor short-term memory, and impaired executive functioning. The most common findings in these studies, I give a reference at the end of this talk for a more recent compilation of the cognitive studies done with mycotoxins. Same thing. In every study ever done, mold makes cognition worse. That's the executive summary there. And one more study, and possibly the most frightening, on cognitive impairment in mold. Almost 300 Polish children were studied from birth. At age 6, the children living in homes with visible mold were almost 10 points lower on IQ testing. And there was an almost direct relationship between the time of exposure and the IQ decline, with people spending 3 years in homes with visible mold showing a 5-point decline. Follow-up has never been provided. And let's just remember the study living in Arizona. Swamp coolers are still very prevalent in the poorer areas of Arizona and are very associated with mold. and most likely are linked to poorer performance in Arizona schools in national testing, in my opinion. That's an aside. Okay, so having commented now on the few studies directly available on neuropsychiatric function in SIRS, I'm now going to discuss the far more extensive research on neurological and psychiatric illness related to inflammation in psychiatry and neurology. And neurology is becoming increasingly aware that inflammation plays a major role in many of the diseases they treat. So cytokines are immunoregulatory proteins that are secreted by various components of the immune system. They carry signals, they talk with one another, and they contribute greatly to the inflammatory response in SIRS. MMP9 and TGF-beta we use in diagnosing mold illness all the time, and both have a role in increasing blood-brain barrier permeability, activating glial excitotoxicity. And the others listed here, such as IL-6, are very well explored in psychiatric illness. Now, the next 3 slides show the overall state of the art and summarizing the research in mood and anxiety disorders. And I'm presenting this meta-analysis with levels of evidence here to give you an overview of the strength of this research. And as you can see, it's not hard to find elevated inflammatory cytokine in mood and anxiety disorders. You can note the highlighted columns. That cytokine is called interleukin-6. Remember, we really are studying it now again in COVID as the initiator of the cytokine storm. And it's also one of the most studied cytokines in neuropsychiatry. And you can see every study listed here has found inflammatory cytokines associated with mold. Here are the 4 major meta-analyses of depression, and again, all found elevated cytokines associated with depression. And again, I've listed some of the most recent references from 2019 and 2020 at the end of this talk, just again to increase the proof that every year we see more and more very strong scientific research linking inflammation and depression. The same is true for anxiety. And again, here are the meta-analysis of anxiety and OCD. And again, showing increases in pro-inflammatory cytokines. And I do have the impression that OCD, the trait as well as the syndrome, is pretty common in SIRS, especially children. And it'd be interesting to study that. Usually now we're looking at this as full autoimmune encephalopathy in PANS. Inflammatory cytokines have been found in bipolar illness. Studies show strong association with the presence of inflammatory cytokines. And in my experience, bipolar symptoms plus the brain on fire from mold is extremely difficult to control unless you recognize the root cause inflammation that's environmental. Here's one of the studies showing microglial activation in the presence of elevated peripheral cytokines demonstrated in bipolar disorder. And just microglia are the primary homeostatic guardians of the central nervous system. They exert really critical functions during development and neural circuit reshaping and during adult life in the brain. And they have a dual role in both guiding the growth of new neurons and in neurodegeneration. Extremely important. And in general, microglial activation is synonymous with the word neuroinflammation. So microglial activation has also been studied in the development of schizophrenia. And here's a really recent excellent study I like to quote a lot, showing that inflammation, here the green brains of these young children who were taken as being at risk for schizophrenia, that the inflammation preceded to the development of actual schizophrenia. This is an increasing gradient of microglial activation in the brains of children at risk. And they did not list the causes of inflammation. And again, I think we have listed a number of them already. So Alzheimer's, not surprisingly, has been listed with neuroinflammation also. And a number of cytokines have been linked with it. TGF-beta, which again, we see a lot elevation in mold, consistently elevated in Alzheimer's as well as in mold illness. And you can see all the others which are listed here as being associated with Alzheimer's. I've personally seen at least 2 patients, given the clinical diagnosis of Alzheimer's, who were released from the Alzheimer's clinic when I treated their mold. And I've seen a number of patients who totally believed they were on their way to developing dementia, as did some of their family members who regained normal cognitive function with mold treatment. It's shaping up in the Bredesen protocol to be probably one of the most important, if not the most important, environmental toxin to look for in patients presenting with dementia. Okay, so I've mentioned that passive suicidal ideation, meaning you're hoping death might happen when you wake up, but have no plan or intent to do anything, can be common in SIRS. And a number of patients over the years have also told me that they can be feeling really pretty well, walk into a building and start having very strong suicidal thoughts they'd be better off dead. They know they're getting mold exposure because this has been publicized by myself and other doctors and patients. It happens as a warning that they have had some inflammatory toxicity. But it is quite startling to see that suicidal ideation can be turned on so suddenly and turned off when people walk out of the inflammatory situation. So not surprisingly, suicide, this is not, quote, psychiatric. You can really see a number of studies showing suicide is linked to inflammation. The recent evidence points towards a low-grade inflammation in the brains of suicide victims. Quinolinic acid, which I'm going to talk about in a second, is produced in neuroinflammation through the degradation of tryptophan, increases glutamate excitability, and it's known as excitotoxicity. And that, again, has been associated in several studies with suicide and suicide ideation. This is a very nice chart diagramming how peripheral cytokines, which are present in SIRS, increase the inflammatory breakdown of the neurotransmitter tryptophan to the inflammatory acids, kynurenic acid and quinolinic acid inside the blood-brain barrier. And it's associated with a number of undesirable events, including cognitive dysfunction and neuronal injury, and as we've just talked about, suicidal ideation and suicide. Now, this is a little less well known than quinolinic acid, which is fairly well known in the psychiatric community. Vascular endothelial growth factor, familiar to most of us as VEGF, is a very important player in the brain, and most of us are acquainted with its role of increasing blood flow through increasing capillary growth in the extremities, in the hands, in the feet, and in the eyes. But in the brain, it has an expanded role in actually regulating the growth of new neurons, synapses, and glia by regulating neurogenesis, synaptogenesis, and glia. And think for a moment how important that is. That is neuroplasticity. Fortunately, in mold, VEGF is usually quite low and is associated with the fatigue that may take a long time to resolve. In one of the best studies I've ever seen on study, a long-term prospective study done Karolinska Institute in Sweden, VEGF and low VEGF was associated with suicide. In fact, it was the strongest association they found in the brains at autopsy of successful suicides. So I can only speculate that perhaps decreased blood flow to the brain with lower oxygenation may make impulse control by the frontal lobes harder, make controlling impulses harder, or it may actually lead to the depressive thoughts with, again, the neuroinflammation that would be present. So we're getting here, and remember, I just have half an hour, so I am running through this. I could spend a long time on everything here. Is that SIRS causes dysregulation both of the immune system and the hormonal system. We've just spent a lot of time discussing the inflammatory components of the immune system, such as cytokines. However, neurohormones are also dysregulated. And I think, as most of you already know, hormones are very important in mood regulation also. So this is a slide I like a lot. It's showing what it means to have resilience, or the ability to handle stress successfully. In one, a mouse is standing up to a cat. That mouse has resilience. Low resilience, which is something we're seeing increasingly as the pandemic drags on, is slouching away from the predator cat without putting up a fight or even trying anymore. And this is low resiliency, very much linked with depression and learned helplessness. This is a very nice diagram of the mechanics of cortisol, which has been shown to play a very important role in resiliency as well as neuroplasticity. And so many people with SIRS have adrenal dysregulation, and presumably that's playing a role in the neuroinflammatory and cognitive symptoms we see. And so here you can see cortisol, of course, is produced by the adrenal glands, and the role it has in regulating neuroplasticity through brain-derived neurotropic factor, decreasing neurotransmitters, and increasing cytokine inflammation. This is, again, a briefer explanation than this topic really warrants. And vasopressin, or antidiuretic hormone, is very well studied again in SIRS. It's just frequent urination is very, very common. When we look at antidiuretic hormone, measure it, it's usually non-existent with changes in osmolality. So this is very interesting, as vasopressin's actually been studied as a neurobehavioral hormone along with its kissing cousin, oxytocin, located right next to it in the brain. And vasopressin has been best researched in prairie voles, not humans. And prairie voles mate for life. They are monogamous, and they've been shown to be related to the high levels of both oxytocin and vasopressin they produce at the time of initial mating. This is wonderful for prairie voles. No such love potion has been found for humans. But several studies have shown that higher antidiuretic hormones have been associated with less negative social interaction with the patient's partners. And antidiuretic hormone in humans is felt to be important in relationship maintenance processes, meaning getting along with others in humans. And who knew, or who would ever think that a water retaining molecule would affect behavior? And take-home message is, again, in the whole neuropsychiatric symptoms of SIRS, marital discord is extremely common, irritability, and sometimes I'll just tell people while waiting for your antidiuretic hormone to normalize, because it often will, it does pay to count to 3 before responding to your mate. I've included this slide to just show the very strong research, again, on treatments that are related to improving gray matter neurogenesis. This lists all the studies that would have been done since, again, growing your gray matter or reversing neurodegeneration is extremely important for many people. And these are some of the interventions: VIP, vasoactive intestinal peptide, which is inhaled. It's also, again, very important in COVID. It's helping people get off respirators. Exercise, diet, actually antidepressants and ECT have been shown to increase gray matter. Point that out after I've kind of given them a poor rap in the beginning of this talk. Meditation strongly increases gray matter, and a couple of supplements, curcumin, zinc, and taurine. And these are many of the interventions. Some of the interventions, others such as sleep and other supplements, will also contribute to being able to regrow the brain. So despite our exposure to toxic insults, we are able to affect positive changes. The brain is not static. This is the updated bibliography I've provided of just, again, showing how many more references. This was just in the last pretty much 6 months or so are coming out, despite all attention being focused on COVID. many researchers are still researching inflammatory cytokines. So I hope this brief introduction has stirred your interest in looking at root causes of psychiatric illnesses, and thank you for listening.